Mr. Smith, how are you? Are you doing okay? Yeah, I feel like you got some stuff stuck in that tracheostomy. All right, let me get some gloves on here. So I'm Miranda. I'm going to be your nurse. I'm going to take a quick listen to you and see how your lungs sound, okay? Do you care to just go ahead and tell me your name and date of birth? Make sure I got the right person. All right. If you don't care, I've got some students here with me today, and as I do this, I'm going to kind of talk to them and tell them things to look for. Is that okay with you? All right. Yes, sir. All right, I'm going to take a quick listen just to a little bit of your lungs. If you can just take a deep breath in and out. Deep breath in and out. In and out. Good job. As a reminder, these are the areas of the lung fields that you should auscultate. I just wanted to listen again. I know we listened to all of your lung fields earlier, but I wanted to listen one more time before we do this. We're going to go ahead and do some tracheal suction. So we're going to put that suction catheter down this trach in order to get some of those secretions out. Is that okay? Now, I know your trach is new and you haven't had this done yet, but it's just a catheter and it goes down in that hole there. And when we put that down there, it's going to make you cough. So you're going to cough. And then we'll pull that out and try to suction those secretions. If you can, just try not to fight us or pull the catheter, okay? All right. I'm going to go ahead and get my stuff ready if that's okay with you. All right. I got your curtain closed just in case somebody walks in, your family or something. They don't see us doing this until you're more comfortable. All right. I'm going to go ahead and set up the suction. So I'm going to need my suction canister. I'm going to need my little suction holder, canister holder. So I'm going to stick that on the wall. And then my canister goes right in here. And then I got a couple of tubes. I got a longer one and a shorter one. The shorter one is what actually connects my suction manometer to my canister. So I'm going to hook one end to this metal part on my suction manometer. And then on my canister, if you look, there will be something labeled vacuum. And the one labeled vacuum is the one I'm going to hook this to. And then I have another port that says patient. And I'm going to go ahead and take my longer tube and I'm going to connect that to the patient side. And then I'm just going to go ahead and set this beside you, Mr. Smith, okay? Great. The other thing I'm going to do is I'm going to go ahead and get a pulse ox. So this little device here, it tells me how well your oxygen is, as well as how well your heart is beating. There can be some things, so if your oxygen drops below 90, that can tell us that we need to stop suctioning you and give you some oxygen, okay? We'll also look for your heart rate increasing or decreasing significantly to tell us we need to stop and give you some oxygen, okay? All right, I'm going to stick this on your finger. If you don't care to just leave it there, that way when I pull my table around, I don't hide it and I can be seeing that the entire time I'm doing it. Great, thank you. I'm going to gather the rest of my supplies. So I'm going to need this little ambu bag. I'm going to pop this open. And this is how I'm going to give you oxygen, or I'm going to hyperoxygenate you prior to putting that suction catheter down. We want to make sure that we get your oxygen as high as possible, because when we stick that down, it's going to cause you to lose a little bit, okay? So I'm going to go ahead, and when I get this out of the bag, it's going to have a mask, but since I'm going to be hooking it to the patient's trach, I don't need the mask, okay? Now, the oxygen tubing goes on the end of our ambu bag. And Mr. Smith, I'm going to set that beside you. And then back here, this green flow meter, this is my oxygen flow meter. And that's where I'm going to hook this tubing from my resuscitation bag or my ambu bag, sometimes called a BVM or a bag valve mask. So I'm going to hook that back here. And what I'm going to do is I'm going to turn this, and the flow meter goes all the way up to 15. So I want to turn it up, but I want to go as far as it'll go until this stops turning. So I got it up all the way. That helps me ensure that I'm providing as much oxygen to the patient as possible. Now, if the patient, I'm just going to talk through some things with them, Mr. Smith. So if our patient was on a ventilator, the ventilator will have a button that says 100% oxygen, and we can push that button and it'll provide them that hyperoxygenation, and we don't have to do the ambu bag. That's a better option for a patient on a ventilator. Mr. Smith does not have an oxygen delivery source, so he doesn't have a trach collar or anything like that giving him supplemental oxygen. If he did, then I would need to take that into consideration and ensure that I'm replacing that as soon as I pull my suction catheter out. Okay. All right. So the other things that I need are going to be my drape. So this is going to ensure that I can just stick this over Mr. Smith's chest so none of those secretions soil him. I'm going to grab a couple of pairs of sterile gloves. I like to have 2 pairs just in case something happens, right? I have a backup pair. I'm going to grab my suction kit. So we have the suction catheter kits that have everything we need in there, and that includes our little basin in order to do this. I've also got some sterile saline. Now I can use 0.9% sodium chloride or sterile water for this procedure. I do want to make sure that if I'm opening this, that I date, time, and initial it. So this has not been open, so I'm going to go ahead and have my sticker here to date, time, and initial it once I'm done. I'm just going to set that to the side. All right, Mr. Smith, I'm going to go ahead and drape this over your chest. Okay. And then we're going to go ahead and set our suction manometer up. And so depending on the age of our patient, it will be different pressure settings. We don't want the pressure to exceed 150 whenever we're providing any kind of trach suctioning. And this procedure is going to go for patients who are getting tracheostomy suctioning, if they're getting nasotracheal suctioning, or even endotracheal suctioning. So this is the same procedure for all those. And we call this open suctioning because we don't have a closed system. We're actually handling the catheter and it's not closed or protected in anything once we get it out of there. Okay. So for my adult patient, for Mr. Smith, I want my suction manometer to be set between 80 and 120 millimeters of mercury. So I'm going to go ahead and do that. I'm going to go ahead and set this for, I'm just going to do 100 because he's not had suction yet since he's had this in. So I want it to be a little bit lower. If I had a smaller person, if I had an adolescent or an infant, then I'm going to set that to 60 to 80 millimeters of mercury. The reason for that is I don't want too much pressure going and hitting the carina. So when I advance the suction catheter down, I'm going to meet some resistance. And when I meet that resistance, I'm actually touching what's known as the carina. So the carina is the bifurcation between the left and the right main stem, right? And so we have this kind of happening, right? And so my catheter is coming and it's hitting this area. So I need to pull that catheter back about 1 to 2 centimeters or half an inch because I don't want to apply suction to that area. We could cause an ulcer or skin breakdown and cause the patient more problems, right? Okay, so I've got all that done. We got our suction manometer set up. I've got this. Mr. Smith, I'm going to raise you up a little bit just so I don't have to bend over. Get you closer to me. I'm going to go ahead and put this rail down just so I have easier access to him. Make sure my suction tubing is where I can reach it. I've got my pulse ox where I can see it. All right. All right. At this point, I'm going to go ahead and take off my clean gloves. I do have some alcohol gel here that I'll go ahead and clean my hands. All right. I'm going to set up my kit. And when I do this, I want to put my bedside table kind of in my line of vision but I want to make sure that I'm not covering up the pulse ox. So I'm going to set some things aside. I'm going to go ahead and open my kit, and I'm just going to peel it open. And inside here is a little envelope. So I can just grab this envelope and set that to the side. So this is going to be my sterile field. So I'm going to open this up, and the first thing that you notice is over here to the side, there's a little basin. So before I continue, I'm going to go ahead and pull this little basin out and open it up. I want to make sure I don't touch the inside because that is going to be sterile. And I'm just going to set it to the side. Okay. Now, before I forget, the next thing I'm going to do is I'm going to grab my solution. So as I said, we're going to use 0.9% sodium chloride. It hasn't been opened, so I'm going to be the first person to open this. However, if I had a solution that was already at the patient's bedside, I would need to do a couple things before using it. First, I would need to make sure that someone had date, timed, and initialed the solution when they opened it, and that it was no more than 24 hours old before I used it. And that does sometimes vary by hospital policy. If it was already open, the other thing that I'm going to do is what's known as lipping the solution. So I have my trash can down here by my feet, and what I want to do is ensuring I don't contaminate the cap and keeping the solution above my waist. I'm going to actually take and let some of the solution come out as I take it around the lip of the hole where the solution comes out. The reason for this is sometimes when we have opened something prior, there is solution maybe that's dried around the opening, and we don't want that in our basin, right? So we're trying to get all that dried stuff off before we pour it in the basin, right? So I'm going to go ahead. The other thing you want to do is put your palm to the label, because if some of the solution does kind of drip down, we don't want the label to be smeared or unable to read. Okay, so I'm going to go ahead and pour my solution in there. I'm going to go ahead and replace my cap and set that to the side. Now that I've got my solution poured, I'm going to go ahead and open my sterile field. And again, taking care to open the top and the bottom very gently so that I don't contaminate anything. Within this field, I'm going to have a pair of sterile gloves and my suction catheter. And remember, you have a 1-inch border around the sterile field. Now, I have opted not to use the provided sterile gloves. Oftentimes, they're more difficult for me to use, so I did bring my own sterile gloves with me, and that's completely acceptable. So I don't want to touch anything until I've actually put on my sterile gloves that I brought with me. So I'm going to go ahead and open these. I like to have room on the ends of my table. Keep in mind that you're not going to be able to open your gloves on the patient's chest or on the patient's bed. You need to have a nice clean surface. All right, and before I put these on, Mr. Smith, does everything seem okay? You have any questions for me? It looks like I've got everything set up and ready. Okay, and we'll walk you through this. So I'm going to open my gloves very carefully. And again, I have my 1-inch border so that I don't contaminate these. And then I'm going to take my non-dominant hand and I'm going to pick the glove up in the middle of the cuff. I don't want to touch this paper because this is my sterile field, right? So in the middle of the cuff, I'm going to pick this up and I'm going to kind of step back a little bit. This cuff is no longer sterile, so I'm going to kind of open it up a little bit in order to get my hand in there. And I'm just going to take my time. And sometimes you'll find that your hand maybe doesn't go in the first time, and that's okay. Don't worry about it. So if this happens, it's not a big deal, right? We're not going to touch it because we don't want to contaminate it. What we are going to do is we are going to go ahead and put on our other glove. And so we want to put the inside of the cuff in our hand. So I'm going to take a minute and hold this paper so that I don't sling it around. And I'm going to try to get this cuff on my hand. And so you can see, you can't even tell that some of my fingers were out, right? And so I'm going to go ahead and step back. Whenever this hand goes towards this glove, this thumb needs to come back because I don't want this cuff that's now going to be non-sterile to get contaminated this thumb. So thumb up, this hand in, and again, I'm just going to work it in. That one went in much smoother, so now I can fix this one that didn't go on as smooth. Okay. Again, just making sure I don't touch anything below my wrist because that is no longer considered sterile. Okay. I'm going to just make sure I get these on good. Okay, so I'm going to go ahead and leave that paper there. I don't need to worry about it. If you noticed, I didn't do hand hygiene again before I put my gloves on, my sterile gloves on. Keep in mind that when you're doing sterile procedures and you have regular gloves on, you may not have hand sanitizer right at the bedside table, right? It may be at the room where you walked in. And once I set my sterile field up, I'm not really able to go and do hand hygiene if I don't have something on my table, which is very unlikely in the acute care setting, right? So, and that's completely acceptable. All right, Mr. Smith, I'm going to go ahead and I'm going to grab my catheter here, and both my hands are sterile. And so I'm just going to kind of get this comfortable in my hand. Okay. I like to kind of wrap it up and get a feel for it. So what I'm going to do is I'm going to put the catheter in my dominant hand, and I'm going to have this little piece of plastic kind of sticking out. So however you want to do it, everybody does it differently, but kind of wrap it in there to where you can hold this little piece of plastic. Now for this procedure, I'm going to have a sterile hand and a non-sterile hand. Okay, so I want to make sure that I'm ready before I contaminate this non-sterile hand. So make sure you've got this where you want it. Now I'm going to go ahead and contaminate this hand. I've got my suction on, and earlier when I set this up, I kind of did this number where I put my thumb over it and I can hear that it's applying suction. I'm also going to test it another way. So I'm going to go ahead and hook this in. I want to make sure that my sterile hand doesn't touch anything over here on this side that's non-sterile. Once I hook this up, the plastic piece is now going to be non-sterile. Just the catheter is sterile at this point. I'm going to go ahead and stretch my catheter back out, keeping care not to touch it to anything non-sterile. This is our vent. It's basically a hole. An open vent is not applying suctioning. So right now, this is not getting suction. When I put my finger over it, that applies suction. So I'm going to apply suction and I'm going to soak up a little bit of that fluid so I can see that my catheter is actually working. I want to ensure those couple of ways that it's working and suction is being applied before I traumatize the patient and stick it down and it doesn't work. Okay, so it works. My patient's oxygen looks really good. They're 98% and their heart rate's 82. Okay, I'm going to hold this catheter kind of out in front of me, ensuring that none of this non-sterile stuff touches my sterile hand. Next, what I'm going to do is I'm going to apply some oxygen. So I'm going to do what's known as hyperoxygenate the patient with a minimum of 3 breaths, giving each breath over 1 second and giving a breath every 5 to 6 seconds. Okay. All right. So let's begin. Mr. Smith, we're going to give you some breaths. Okay. So this little thing goes over top his inner cannula, and I'm going to go 1, 2, 3. He's 100%. So I'm going to go ahead and take that off. And again, sit that to the side. All right. I'm going to go ahead and insert the catheter, Mr. Smith. I'm going to keep care, guys, to ensure that this catheter doesn't touch anything non-sterile, as well as this sterile hand cannot touch anything non-sterile. So I'm going to grab this and I'm going to take it and stick it down there nice and quick until I meet resistance. So I'm at resistance. I'm going to pull back about 1/2 inch, and then I'm going to start to cover that vent or apply suction. And I'm going to kind of twist the catheter as I'm applying continuous suctioning and kind of pulling that catheter out. I'm going to wrap that back up to keep it protected, and I'm going to go ahead and reoxygenate the patient. Right? His sat's down to 95, so we're going to give him those 3 breaths. Observe. Great, so he did great. Now I can suction him one more time with this same catheter in this same kind of encounter with him. I cannot suction him more than twice with this catheter in one encounter just because of the trauma it could cause to the trachea. I do need to wait a minimum of about 60 seconds prior to suctioning the patient again. And again, ensuring that I'm performing that hyperoxygenation prior to each of those suction attempts. Okay. Now, the other thing that I want to do is if the patient needs suctioned in his mouth or his nose, I can go ahead and use this catheter, right? Our nose and our mouth are not sterile. However, just be sure that once you've used the catheter on the nose and the mouth that you never return and use that back on the trach. Okay, so at this point, we've provided suction. He's doing great. His pulse ox looks good. I'm going to go ahead and disconnect the catheter. I'm going to go ahead and take it and pull my glove off and keep that catheter inside of that glove. And then I can dispose of that. And then I'm going to get him all cleaned up. You did great, Mr. Smith. And once I'm done cleaning him up, I'm going to go ahead and I'm going to go out to my computer and I'm going to document. The things that I want to document for Mr. Smith is how he tolerated the procedure. So he tolerated it very well. He didn't try to pull the catheter out or fight me, which it could happen. It's understandable. We want to document the amount of suction that we had the suction manometer on, the size suction catheter that we used. So we used a 12 French. How many times we suctioned the patient. So we did 1 pass, right? And that we did that pass using sterile technique. I also want to document the amount and the color and consistency of those secretions that I did suction out of Mr. Smith. I'm also going to be ensured that I have documented what his lungs sound like, that I had him to attempt to cough, and that I provided hyperoxygenation in the form of an ambu bag with 3 breaths prior to each suction attempt. All right, Mr. Smith, I'm going to get you cleaned up here and get your bed back down and get your side rails up and get you your belongings. And I'll leave you alone for a little bit, okay?